It's my pleasure to welcome you all. The mission of SkIN Canada, or SkIN Investigation Network of Canada, is to advance SkIN research in Canada by creating a national forum. This is guided by knowledge users and patient participants. SkIN Canada exists to strengthen and harmonize collaborations and capacity in the SkIN research community. SkIN Canada's training committee, as we all know, is a very vibrant entity and is very much training centered. The training committee's focus is to improve our capacity building, as we know, and also educational curriculum development and providing opportunities for leadership and mentorship. As such, the training committee designs strategies and opportunities to train and mentor and support the next generation of SkIN research leaders in Canada. The training committee webinar series aim to cover the topics based on the priority setting initiative that has been put in place by SkIN Canada. Today's topics, as we all know, is Hidradenitis Suppurativa, and we have three exemplary speakers: a clinician investigator who does research on this chronic, recurrent, and painful condition, a patient representative who suffers from this skin disorder, who will give us her experience with this disease, and also a trainee who does his research training on this topic. Our moderators for today's webinar are Professor Holly Sparks from the University of Calgary and Dr. Mani Hassan, a postdoctoral fellow from McGill University. Dr. Sparks will initiate the session now by introducing our first speaker. Thank you, Dr. Sparks.
Thank you very much, Dr. Phillip, and welcome everyone to today's webinar. I'm very happy to have you all here and very happy to have the privilege of introducing our panel of speakers here today. So today we'll start just with a quick sort of introduction to how the day will go. So we'll have our speakers present each in their allotted time, and then I'll ask you to just reserve your questions, please. You can actually put them directly into the Q&A box. And then we'll hold a panel session at the end of the webinar today where we'll address all of those questions and hopefully have more of a discussion on this condition and some of the research and experiences underlying this condition. So without any more ado, it's my pleasure to introduce our first speaker today, Professor Vincent Piguet, sorry. So he's obtained his MD and PhD in 2000, 2001, and a specialist certification in dermatology and venereology in 2004 from the Swiss Medical Association. He also obtained his UK certification in dermatology in 2011, and in that same year was appointed as director of the Institute of Infection and Immunity at Cardiff University. In 2014, he became a fellow of the Royal College of Physicians, and in 2017 was appointed as full professor and department division director of dermatology in the Department of Medicine at the University of Toronto, as well as the division head of dermatology at the Women's College of Ontario. And it's here where he established the HS Clinic, which is the first of its kind in Canada. So Professor Piguet has authored over 230 publications in the field of dermatology and virology, and he is the past president of the European Society for Dermatological Research, as well as the European Dermatology Forum. And in 2017 was honored with a membership of the Academia Europaea. So he will be here today to present his topic entitled Inflammation Pathways and Comorbidity in Hidradenitis Suppurativa. So welcome.
Thank you very much for the very kind invitation, Dr. Phillips, Holly, and Dr. Hassan. It's a great pleasure to be here today and to cover the topic of HS. I'll try to share my screen, so let's hopefully that will work. Is that okay?
It looks good, but we can see your, yep, there we go. Perfect.
Okay. So let me see, I just need to adjust that. All right, so the topic is inflammation pathways and comorbidities in HS. I work at the University of Toronto and our clinics at Women's College Hospital. I have some disclosures as head of the division. I fundraise for the program, so I have quite a lot of disclosures to make. They are all on that slide. I try to avoid bias in this lecture by having, maintaining concordance with accepted practice, and then having reviewed with peers some of the slides. But one of the disclaimers is AbbVie says Humira, which so far is the only licensed biologic for HS. So we talk a little bit about that. So just to start, I'll give a bit of an overview of dermatology and inflammatory skin diseases. And then after that, I'll focus much more specifically on HS. So a major role for the skin is protection. The protection is against a lot of injuries, mechanical, thermal, liquid loss, pathogens, and UV radiation. And when there's a defect in any of these processes, for instance, in atopic eczema, you have a defect in the skin barrier that can lead to a dysregulation of the immune system. And that is very, very relevant for HS, as we will see. So when you combine, all the severe pathological processes, you can have a wide range of very severe diseases that affect the skin. And of course, today we are more interested in inflammatory diseases. The picture, the second one on the slide to the left is scleroderma, which is an autoimmune disease, but obviously diseases of inflammation can be very severe. And among them, we have things like psoriasis, eczema, and HS, to name just the most frequent. Dermatology science has really evolved tremendously in the last 10 years. And we went from what was historical diagnosis, and that's the French tree of Alibert, that each leaf is a skin disease. And unfortunately for our residents, learning dermatology is still, I believe, 2,000 leaves, so 2,000 diagnoses. But of course, in the 20th century, a lot of work was done to correlate pathology with the clinical presentations, and that led to non-targeted therapies. More recently, however, as we understand now mechanisms of disease, we can have highly effective targeted therapies. And the picture there is a picture of psoriasis with psoriasis arthritis, and as all of us are familiar, there are now a number of biologics that specifically target inflammation in psoriasis. So my research is, I do work in immunology, and we've done a lot of work on dendritic cells, which are cells in the immune system that initiate inflammation. But I also have conducted research more on clinical areas such as psoriasis or HS, and looking at, for instance, outcome measures or other aspects of disease, comorbidities, and so on and so forth. So just to come back to inflammatory skin diseases, and if we think in gastroenterology, for instance, they have IBDs, the inflammatory bowel diseases. I kind of like to see the skin in a very similar way, where we have inflammatory skin diseases. And then based on the immunotypic profiles, you have different presentations or different diseases. And these are examples of these diseases, the most common probably being atopic eczema or perhaps psoriasis. Psoriasis is a Th17 mediated disease, whereas atopic dermatitis is largely a more Th2 disease. HS, or Hidradenitis Suppurativa, is not so clearly understood, and I'll show some of the immunology later. And of course, there are other diseases of inflammation that affect the skin, for instance, pyoderma gangrenosum, and so on and so forth. And when you combine all of these, they are very common, in fact. And even like if you look at how often family doctors get requests for a skin complaint, it's probably close to 10% of the visits. So it's a very, very frequent issue. So the pathways, however, as I mentioned, they're quite different. In psoriasis, for instance, you'd have more of a Th1 and Th17 pathway, as the slide shows on the left. Whereas in contrast, in atopic dermatitis, it's more of a Th2 disease, where you have a lot of the cytokines that are involved in Th2 inflammation. So what about HS? And I'll come back to that in a minute. So if you look, for instance, at psoriasis, we understand it a lot better, actually, than hidradenitis suppurativa, because much more research has been done. We think that about 2% of the population in the US and Canada or Europe is affected by psoriasis. And about a third of the patients are moderate to severe. And in psoriasis, we understand it quite well. There are really two major axes of inflammation. Mostly the Th17 plays a role, but also a little bit of Th1 via TNF, for instance. And when we block that, the disease, of course, is very well controlled, particularly if we target the newer targets such as IL-23 or 17s, all these cytokines in the Th17 pathway. And this is a slide from some of my friends from the UK when Frank Nestle, John Barker were in London. And this is already 12 years old. This is a New England Journal from 2009. And you can see on the slide already how well we understood psoriasis back then. All the key cytokines had been somewhat earmarked. The initiation of inflammation had been discovered with the probably the essential role of microbial peptides such as LL37 that trigger dendritic cells activation and the sort of initiation of inflammation. In contrast, we know far less for HS even today. So when you look at psoriasis, however, most of the research is done on plaque psoriasis. And when we look at different phenotypes of the disease, for instance, pustular psoriasis or nail psoriasis or mucosal psoriasis, it's very likely that the inflammation is different. In fact, we know that already. Some cytokines are more important, such as IL-36 or other cytokines in the pustular forms of the disease compared to the traditional forms of the disease. So that will conclude with sort of general aspects of inflammation, and I'll move now to HS. So hidradenitis suppurativa has a very large impact on quality of life. It is actually probably similar or worse even than severe psoriasis. And the reason is quite obvious. I mean, the definition of the disease is that it's a disease characterized by inflammatory nodules, abscesses, scars that affect the axillary region and the groins, and you need the element of chronicity. So it's a recurrent disease that will affect the patients. And the prevalence is not fully known. For instance, in Canada, we don't really know exactly what's the prevalence of HS, and it varies quite greatly when you look at different studies. If surveys are done, for instance, with questionnaires, you may have numbers such as 3% of the population. But then in insurance claims, for instance, in the US, it's a much lower number. So several years ago, we did research on that subject with John Ingram when he was a resident and then a lecturer with me in Cardiff in the UK. And these are some of the typical patients we were seeing in the clinics, and they are very similar to the patients we see in Canada. Of course, with the disease, you see the prominent scarring, and the disease is very painful. And so we started looking at the demographics of cases of HS in the UK, and we realized that well, as expected, the female predominance, there's about 2 to 3 to 1 compared to male patients. There's a major peak of prevalence around 30 to 40 years old, but often the disease starts earlier. And the actual, when you look at the validated population, this is in an article in the British Journal we published about three years ago. And so if you're interested, you can have a look. The validated HS prevalence was close to 1% in the UK, so 0.77%. But when you look at the possible cases, those that were not confirmed, it could go as high as 1.2%. So we think that, at least based on the UK population, and it's not exactly the same in Canada, but we think that 1% of the population is probably the right number. The overall female to male ratio is almost 3 to 1. And we obviously observe the same associations with a number of comorbidities than other authors had already shown previously, that it's associated strongly with diseases like Crohn's disease, but not exclusively. There are also other factors that I will discuss more. So if you look at a picture of the comorbidities in HS, you can see there are multiple. You have the lesions themselves, but there are a number of comorbidities, whether it's impact on mental health, on metabolism. The patients often have weight issues, so obesity is involved, and metabolic syndrome. You have a number of pathogenic factors as well that can contribute, such as smoking. Many patients also smoke. And then, of course, you have disease association, and the strongest is probably the Crohn's disease, but you have also inflammatory disorders that can be associated, and endocrinology as well. If you're interested in comorbidities, the American and Canadian HS foundations just submitted, recently published an article on comorbidity screening in HS. The reference is at the bottom of the slide, and I was one of the contributing authors to that study. So when we look at HS, actually, what you realize is, although it looks superficial on the skin, sometimes there are deep tunnels. And what I'm trying to show here is an ultrasound of HS, and you can see this sort of tunnel going under the skin, all the way across the anatomic region. So it's a different disease than psoriasis or eczema, for instance, because you really have a sort of surgical component to it, and this very deep sort of lesions, if you like, under the skin, deep into the tissues. So there are some genetic associations. There are some syndromes associated with HS. We recently published an article, for instance, on Down syndrome, which is associated with HS. So we think, of course, there are some genetic elements or genetic factors that increase the risk of HS. And there are many associations that have been described, for instance, Darling-Douglas disease or Sapho syndrome and so on, that can be associated with HS. More specifically, we think there are a number of different factors, and that's a very simple slide. That's now a little bit dated from 2012 from the Netherlands, from the Dutch group. You can see that there are genetic factors involved, the microbiome, the microbes are involved. There's also a dysregulation of the immune system and then environmental factors. So how do we make sense of all of that? Right, so the environment, it's sort of relatively well understood. We know, for instance, that smoking and obesity increase HS. And so smoking as well as weight can have a pro-inflammatory effect. So, and then there's a number of literature on that. And that's one of the, let's say, external elements. But we also think, of course, there are genetic predispositions, whether it's maybe hormonal in some case, maybe it's around the follicle, the hair follicle plugging, and the formation of cysts that maybe has a genetic component to it. And then, of course, there's the disease propagation, and that maybe we think bacteria play a role. Inflammation plays a role. That's sort of a subsequent step, which is generally when the patients will consult with us, is when they have actually already pretty significant abscesses and inflammation. So this is a slide showing the apocrine or pilosebaceous apocrine unit. And we know already that there are some mutations in those in some of the genes in this unit that may contribute or may be associated with HS, such as, for instance, mutations in the gamma secretase or the Notch pathway. So that led some authors. This is a German study asking the question whether the origin of HS is in the infundibulum, so in that part of the hair follicle. And so it's still debated, but it's a possibility, that that's where the inflammation is initiated. This is an example of some of the studies done on mutations. And so, for instance, mutations in nicastrin, which is one of the subunits of the gamma secretase, can be associated with HS. There was work by groups in China as well as in the UK. This is a study from Andrew Pink, who is in London, at the St. John Institute. And he did his thesis trying to study, I was his actually external expert for the thesis, so I know his work quite well. And he actually mapped the mutations in the British population in that gene. And interestingly, it was not so frequent in the UK. So these gamma secretase mutations only account for a small proportion. So there's a lot of additional genes that we don't yet know about. So as I said, although genetic factors play a role, we think also bacteria play a role in HS. And we know that HS is not an infectious disease. The presence of bacteria does not mean infection. And in fact, lymphadenopathy, or a true sort of infectious process, is uncommon in HS. However, we do find a lot of bacteria, and there are some of the references to some of this work. So the way we think, and this is a review from Julia Segre, Yasmin Belkaid, and Alison Bird, who has done really outstanding work. Alison has done excellent work on HS, which shows the crosstalk, in fact, between the immune system and the skin microbiome. And we know, for instance, that changes in bacterial species that can be observed, for instance, in HS, may correlate with more inflammatory stages of the disease. So this is an example of, this is one of those, I think, very short article in Nature. That's more like a diagram type article. And we understand quite well in atopic dermatitis how the microbiome, can, for instance, staph epidermidis can maintain tolerance, but when you have too much staph aureus, the eczema will get super infected, and there'll be more inflammation. We don't know quite as much in HS, but we think it's probably relatively similar. If you look, for instance, at microbes in HS, there's an increase in certain communities. There's also staph aureus and some Corynebacterium abundance can be associated with disease severity, and there are also some other bacteria. So this is an example of one of the first studies by Ring and al., which is in JAMA Derm, showing that HS lesional skin has a different composition compared to healthy controls or even non-lesional skin. And that was one of the studies. And more recently, there's been a study by the group from Institut Pasteur in Paris, which showed also a different cluster of microbial populations in HS. And they look, for instance, at the unaffected folds, and they also found a different cluster of certain bacterial types. So how do we think about that? Well, bacteria, in addition to sort of the microbiome, there's also the formation of biofilms in HS, which contribute to disease and prevent healing. So in addition to the sort of dysbiosis, there's also biofilms represent a challenge to treat patients with HS. So if we try to do a diagram of a simple diagram, this is a review that Haley Naik at UCSF and myself and a few others did on infection versus dysbiosis in HS. And we think that under normal circumstances in HS, you don't have a true infection, but the commensal microbes cause immune activation via dysbiosis. And although it's less well established than in atopic eczema, as I was mentioning earlier, it's likely to be relatively similar. And pathogens, although are not directly infectious, they contribute to the inflammation in HS. But in addition, of course, to bacteria and microbiome, HS is an immune-mediated inflammatory disease. As I mentioned earlier, one of the established therapies for HS targets TNF-alpha and offers significant relief for the patient in the range of about 60% efficacy, depending on the studies. However, there are a number of other cytokines that are elevated that you can find, for instance, IL-10, IL-17 in HS lesions. And you can also find a lot of systemic inflammation in HS. This is, for instance, a study by Jimenez Gallo and colleagues showing all the cytokines you can identify in HS, and you have increased levels, for instance, of IL-6, IL-8, of course, CRP, et cetera, So there's a number of, there's a lot of evidence that HS is disease of inflammation. There's some questions about the potential role for complement. It's attractive to think that the complement pathway plays a role because bacteria, as I mentioned, activate the complement, and so and the complement also regulates the inflammasome, so can be at the sort of crosstalk between IL-1, 17, 23, TNF. So all these cytokines that may play a role in HS. However, the clinical trials with complement inhibitors haven't showed a great efficacy, so it's still unclear. So if we look now at potential targeted therapies in HS, and if we go back a little bit to how the disease, let me just check the time. Yeah, I have a couple more minutes. I'll try to accelerate. We can see there are a number of steps in which we could target. And for instance, the microbiome can be a target. Some cytokines can be a target. There was a nice study from Angel Bird in Science Translational Medicine in 2019, showing, for instance, that neutrophils and type 1 interferons may contribute to the disease in addition to some of the other pathways. So we reviewed that recently in the Journal of Investigative Dermatology. This was an article led by John Frew, and I think I was the senior author on that one. This is all the novel therapeutic targets that results from that research. So is IL-1 a good target? Is IL-17, 23, 36, complement, JAK-STAT pathways, and bacteria? So I think you could see there's quite a number of potential targets, and a number of clinical trials are ongoing trying to identify which ones of these targets will be of the greatest clinical relevance. So just to finish, I'll finish with that. A couple more slides. This management of HS, it's a combination of antibacterials, biologics, sometimes surgery, but also factors such as stopping smoking, weight loss, pain management. So managing all the comorbidities as well. And basically the treatment depends, if you have more inflammation, we tend to try to use anti-inflammatory treatments, where if it's more on the scar and sinus formation, maybe surgery will play more of a role. So I'll conclude with that. HS is a chronic inflammatory skin disease with multiple phenotypes associated with numerous comorbidities. The pathology, the pathophysiology of HS is multifactorial. There's a key dysregulation of the immune system. There's a role for bacteria, for environmental factors, and of course, there are also some genetic predisposition. The management is personalized based on the stage of disease, and there's still several areas of unmet need. We need to still understand better the disease to have more efficacious drugs, but also there's a number of other areas such as quality of life, comorbidities, and so on and so forth. I will stop with that, and thank you for your attention. I'll skip this. This is where we work. That's the University of Toronto, and on the right, this is Women's College Hospital. At the bottom is the areas where my lab is. Thank you for your attention, and I'm happy to